Thank you, Acting Speaker, and it's a great opportunity to be able to stand in this place and talk on the Health Insurance Amendment, the National Rural Health Commissioners Bill of 2017. And I was in the House last sitting when the Assistant Minister for Health, Mr David Gillespie, got up and read the second reading speech into the House, and it was great that we have a situation where someone with an extensive knowledge of the health industry, a gastroenterologist, is able to talk on issues surrounding rural health. Someone who has spent an enormous amount of time in the rural health sector as a professional is able to then adjudicate over the introduction of this commissioner. The introduction of the Rural Health Commissioner was a major platform of the National Party in the last election. It was one that the then Minister Fiona Nash was able to put front and centre as more or less a line in the sand, saying we cannot accept this inequality that exists in rural health and regional health any further. We need to understand that, yes, we might have enough doctors when you look at the Australian population and divide it by the amount of GPs and the amount of specialists that we have. However, it would be a fool to suggest that we've got all those doctors in the right places, and therefore what we need to do is we need to have a continual referencing and a continual filtering to make sure that the health services that we expect for the third of our population that live outside of the major regional cities, then we expect those people to have a very efficient and a very world-class health service. We also understand that that's just not the case at the moment. We also understand very clearly that if you do live in rural and regional, but predominantly rural Australia, you are going to be in that bracket who experience a higher rate of chronic disease than otherwise would our metropolitan cousins. We have a shorter life expectancy in rural Victoria and rural Australia. We have higher risk factors of smoking, excessive drinking and obesity, this is often put in place primarily because in many of the areas we're talking about we have lower wages and lower incomes, and it's becoming more and more apparent now that education has a direct correlation to wealth, and that when you map our wealthier and our poorer suburbs, you get another direct correlation between wealth and health. And of those health areas that the first to shine through from having low wealth in the economy or in the community, you're going to find things such as certain types of cancers. You're going to find the areas such as oral health and dental health are going to be some of the first signs that are going to show very, very poor outcomes, because quite simply people don't have the money to go and get skin cancers checked. They don't have the money to go and get some ailments that maybe are threatening and worrying, simply don't have the time or do not have the money to invest in some of the high-priced services that might be available, and certainly the opportunity to get this work done cheaply sometimes doesn't exist in the regions. Plus the distance to the services becomes cost prohibitive, becomes time prohibitive, and quite simply we know that there are high rates of preventable cancers, melanomas and lung cancers in regional Australia and rural Australia than what there are in metropolitan Australia. I know the Deputy Prime Minister and Leader of the National Party has continually said that it's our job in here to make sure that for those people that are doing it tough, we don't make their life tougher. And I think that's something that we just need to understand. And this bill is going to hopefully create a system where the Commissioner will be able to highlight and pinpoint significant gaps in our health system and our health services, and be able to then report those gaps back to the Minister to be able to bridge those gaps in our health system. The former Minister Fiona Nash, who was able to argue for and deliver this policy through the previous election campaign, has labelled this as a bold and historic commitment, and I want to commend her for pushing this initiative through. And it's something that we're going to make sure that when we have our rural and remote communities, they'll be able to acknowledge that there is someone who's going to champion and to advocate on their behalf to make sure that they get the health services delivered to the locals in their area that they may otherwise be lacking. And I suppose this is where I started. This is because we do have that deep-lying principle that every Australian should have access to a high-quality standard of health care, no matter where they live. And this first-ever National Rural Health Commissioner will be an integral part of the agenda to deliver that more equitable services of health. To establish this role, we're going to have to amend the Health Insurance Act of 1973, and this position will be a statutory position, enabling the Commissioner to carry out their duties independently and transparently. We expect that this position will be totally independent, completely impartial, and they will need to be a fearless champion to carry out the roles within this area. The Commissioner will have to work with, obviously, the health sector, the universities, obviously the specialist training colleges across all levels of government, and will certainly have to champion the cause of rural practice. It would be expected that the Commissioner would be someone with extensive experience in the health sector, someone who can consult, obviously, with a whole range of different players within the health sector, and someone who has that real passion for creating some improved outcomes into the future, as opposed to what we're putting up with at the moment. And these positions will roll for 2 years. Once appointed, we expect the Commissioner to develop a national rural generalist pathway. And again, this is something that, sitting down and talking to some GPs last week in my electorate office in Shepparton, it became very clear that once somebody has completed their medical degree, they're about halfway through their training if they wish to become a GP. It's really it's quite shocking when you look at the degree of training and the areas of speciality that we expect our doctors to continue to train and work towards their areas of speciality. But certainly, again, a lot of the trouble that we have in rural Australia is this ability to not just attract but to keep many of these health specialists and professionals in our country areas. And I think if we're able to look at ways where we're going to be able to maintain and retain the health professionals that we are able to attract, I think then we're going to be in a much better position. Also, it's worth acknowledging that in rural Australia, we must understand that our rural generalists tend to have advanced training than do those from a metropolitan centre. We understand that they have a wider set of skills. They have obviously demanded they work longer hours across a whole range of different incidents and accidents that will force them to do work that they may be slightly outside of their comfort levels and their comfort zones. But with just the sheer nature of life in rural and remote Australia, if there's an accident that has happened and an injury has occurred, sometimes doctors have no option other than to act in the best of their ability. We'd also expect that healthcare and plan and programs and service delivery must be adapted to meet the wide different health needs of different communities. And again, one of the areas that I think we can do more work in is this strategy and planning. So we get to the situation where we have most regions would have a major regional hospital, and from them, maybe within half an hour, with 20 minutes, 30 minutes, 40 minutes drive, you would find 5 or 6 other smaller hospitals, and the ability of each of those health centres and hospitals to actually work together in a strategic manner, so that we don't have duplication of service, and then the quid pro quo of having duplicated services is that you have total gaps in other services. And I think the ability for many of these regions to have healthcare plans put in place to make sure that each of these both larger and smaller hospitals are in fact working hand in glove, and to ensure that wherever possible they are complementing each other and working with each other and not against each other. There will also be a couple of other amendments to the Act in relation to the repealing of Section 3GC to abolish medical training review, the Medical Training Review Panel. We understand that in 2014 it was revealed that the Medical Training Review Panel identified a strong overlap between their function and those of the Medical Training Advisory Network. So to repeal the review panel is going to enable this duplication to be cleared up, and also it will remove the burdensome and ineffective process of a 5-year review. This has effectively been the case so far, and yet it's been more or less acknowledged that these reviews have been ineffective, and so therefore I think to take this aspect out of the Act will also be a promising and positive initiative. As I said, we're really looking forward to this Commissioner coming into place. I think that we are going to acknowledge that this is going to be over a $4.4 million investment in rural health, to have that real champion who has the capacity to acknowledge where the gaps are, to acknowledge what's working well. I know some of the PHNs are looking at doing this type of work as well. The health situation we find ourselves in is very, very complex. It's, in many instances it's very frustrating because so much of the health budget is determined by our states. So much of the health funding is delivered to the states by the Commonwealth Government. And generally what you see when you have more than one body responsible for an outcome, and what you normally find is that nobody takes responsibility when things go wrong. So, and this is one of the issues that I think if we were wanting to start and get ourselves a well thought out process for delivering health to all of Australians, we wouldn't start where we are at the moment. But the fact is we've got what we've got, and we have to look at the best way forward. So I think this initiative, driven by Fiona Nash, carried on now by Minister Gillespie, is going to see a real champion with the sole objective of making sure that rural and remote Australians are well serviced by their health needs, making sure that if there are gaps, those gaps are identified, that those gaps are then delivered through, and that information is passed directly through to the Minister for Health to ensure that appropriate action is taken, and that that those services can then be best delivered to those people in Australia who most need it. And the whole conversation will then revolve around, do we have an equitable health system? Are people that live in rural and remote Australia well serviced? And can we start closing the gap between the health outcomes of our people in metropolitan Melbourne versus those in regional cities versus those in remote and smaller and rural communities. Thank you.
Thank the member for Murray.